Hello, everyone, and welcome to today's webinar, Triaging Suspicious Adnexal Masses. Should I be worried about ovarian cancer, and can biomarkers help? I'm Dr. Liza Kunz, a board-certified obstetrician gynecologist and systems director for Endocrinology and Reproductive Health for Core Diagnostics at Abbott Laboratories. I'll be serving as the moderator for today's event. To create awareness and support for the Ovarian Cancer Awareness Month, today's educational webinar is presented by LabRoots and brought to you by Core Diagnostics at Abbott. To learn more, visit www.corelaboratory@abbott.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them in the Q&A box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. Now I'd like to welcome today's speakers. Dr. Kevin Holcomb is an obstetrician, gynecologist, and gynecologic oncologist. He is Associate Dean of Admission for Weill Cornell Medical College. Dr. Ashley Gubbels is staff physician at the Cleveland Clinic, Ohio, in the Division of Minimally Invasive Gynecologic Surgery and Chronic Pelvic Pain. And Dr. Makunda Abdul-Mbacke is a practicing obstetrician gynecologist at Piedmont Preferred Women's Healthcare in rural Southwest Virginia. Dr. Holcomb, you may now begin your presentation.
This is Dr. Kevin Holcomb. I'm a gynecologic oncologist as well as Associate Dean of Admissions at Weill Cornell Medical College. And today we'll be discussing triaging suspicious adnexal masses. Should I be worried about ovarian cancer, and can biomarkers help? By way of disclosure, this program is sponsored by Abbott. I'm presenting on behalf of Abbott. Information contained in this scientific presentation is from me and does not represent new or implied product or regulatory claims. I received research support from Fujirebio Diagnostics Incorporated, and I'm a consultant for Johnson & Johnson. The woman presenting with a suspicious adnexal mass is typically in very much a anxiety-provoking situation, both for the patient and the physician. And that's because of the fear that surrounds a diagnosis of ovarian cancer. It's a well-founded fear. Ovarian cancer is not a common cancer in our country. If you look at these statistics from the American Cancer Society, it's estimated that about 948,000 women will develop cancer in this country this year. But ovarian cancer is not in the top 10 causes. It's estimated that about 19,210 cases of ovarian cancer will be diagnosed this year. And actually, this is an improvement. There's been a nearly 3% decrease incidence of ovarian cancer from 2015 to 2019. The fear of ovarian cancer is related to the fact that it remains the most deadly GYN malignancy in the United States. Unfortunately, there will be about 13,270 women who will die of ovarian cancer this year. And you see that although uterine corpus cancer is more common, ovarian cancer causes more death. It's a situation where the chances of survival from ovarian cancer is tightly tied to the stage at diagnosis. In fact, for women diagnosed with stage 1 disease, the 5-year survival is over 90%. Even in those with stage 2 disease, where there's metastatic disease in the pelvis, you still have about a 70% chance of 5-year survival. Unfortunately, there's a steep drop-off in survival in stage 3 and stage 4. And that is where the majority of women are diagnosed with ovarian cancer. Only 30% will be found at stage 1 or 2, and about 70% will be diagnosed in advanced stages. Part of the reason for this is that the symptoms of ovarian cancer are very nonspecific and they're vague. But I do want to caution that it is not a silent disease. I was taught in training that ovarian cancer is a quote-unquote silent killer. And I think it's a disservice to call it that, because we need to be aware of these vague and nonspecific symptoms, such as bloating and nausea and vomiting and early satiety. Now, admittedly, these are common reasons why women present to their doctors, but that unique constellation of symptoms is very much characteristic of an ovarian cancer diagnosis. And so, if you see a survival in early stage disease like this so high, you would think that here's a disease that we just need a good screen for. And that has truly been the holy grail of ovarian cancer, this search for a screen that would improve survival. It has been studied in the United States. It has been studied in the United Kingdom and elsewhere, usually utilizing a combination of transvaginal sonography and serum tumor markers like CA-125 in some form or fashion. And over the decades, unfortunately, no study has shown that screening asymptomatic women for ovarian cancer will decrease morbidity or mortality from the disease. And I think that sober statement really sums it up from the Centers for Disease Control and Prevention, where they just said there is no reliable way to screen for ovarian cancer in women who do not have any signs or symptoms. Now, that may leave you feeling pretty hopeless and that there isn't much we can do here. But when posed, what can be done to improve survival in ovarian cancer, I'd like to point to some bright spots. One, median survival from ovarian cancer has been increasing over the years, and that's because of more therapeutic options, particularly in women with recurrent disease. Work towards an effective screen goes on, and there are many exciting things in trials right now. But one of the things that we could be doing right now and improve upon would be making sure that a woman presenting with a suspicious ovarian mass is promptly referred to a gynecologic oncologist. Now, I'm a GYN oncologist. I'm not just advocating for more referrals to my specialists. I'm saying that because this is evidence-based. There have been a number of studies, and I'm just going to point to two, that show that survival is improved in ovarian cancer when it's managed by a gynecologic oncologist. And this is not new data. Some of these studies go back into the early 2000s. For example, the Utah Cancer Registry was a study, a rather large study, of 848 patients, new ovarian cancer patients between 1992 and 1998. Now, the sad thing is that only 39% were ever seen by a gynecologic oncologist. And that is true to this day. As you know, many subspecialists are concentrated in large metropolitan areas. There are large swaths of this country where a woman would have to travel some distance to find somebody with a skill set of a gynecologic oncologist. But what they did show in this study was that patients with advanced disease had a significant survival advantage when managed by a gynecologic oncologist. Now, these median survivals don't look impressive compared to today's numbers, but it was clearly shown that women who had a gynecologic oncologist had a significantly longer median survival than those who were managed without one. It's consistent with what was shown in the guiding meta-analysis. This is from 2005, another large study, 18 studies included. And again, they showed marked benefit with a gynecologic oncologist involved. In this study, it wasn't just for advanced stage disease. It showed that women who have apparent early stage disease are more likely to have comprehensive surgical staging. As you can imagine, that correctly classifies people's risk for recurrence and identifies a population who may be getting adjuvant chemotherapy who would not have gotten that without an adequate staging. And for women who did have advanced disease, they showed that there's more chance of an optimal cytoreduction, meaning a cancer surgery that leaves you with very little to no gross residual disease. And they were able to show improved median and overall survival by having a G1 oncologist involved. And so this idea of making sure you get a cancer patient in the right hands from the beginning is not just a theoretical benefit, it's a proven benefit. The problem is that while there are going to be millions of women with a cyst of their ovary, as I stated, there are only about 19,000 cases of ovarian cancer per year. And so this is a bit of a search. Just how many women have a cyst per year that is somewhat difficult to know because many women have no symptoms and are not seeing a physician, and we don't know they have a cyst. But you can get some idea of the frequency if you combine Census Bureau data with the findings of ovarian cancer screening trials, prospective screening trials. For example, using the University of Kentucky ovarian cancer screening programs and the 2008 Census Bureau. That year, there were about 90 million premenopausal women in the United States. And the University of Kentucky study said about 14% of those women will develop a cyst that year. That's 13 million women with an ovarian cyst, premenopausal. Prevalence is about 30%, so that would be 27 million women with a cyst that year. There are fewer postmenopausal women, about 30 million, if you're using age of 50 as a cutoff, but that still leaves you about 1.5 million new postmenopausal cysts with a prevalence of about 5 million postmenopausal women any given year with a cyst. So what do you do for a patient like this who comes to your office with pain, gets a sonogram, and she has a cystic mass on one of her ovaries, and as you can see from the arrows, she's got thick septations, some nodular excrescences, maybe some flow within those vessels, those nodules. Who should be doing this woman's surgery, particularly if she's in an area where she would have to travel for the services of a gynecologic oncologist? How do you decide whether to send this woman? Well, we all know that the risk of malignancy is related to her age and her family and personal cancer history. Those are true predictors of malignancy, but the majority of women with these cysts are premenopausal and they don't have significant family history. So how do you make a decision? Well, pelvic mass assessment really comes down to, outside of the history, a few things. There's the physical examination. Clearly, there may be ascites already present or mental caking on the physical exam or obvious adenopathy, things that would make you much more concerned about a cancer. You have imaging modalities, sonograms, MRIs, CT scans. You've got serum biomarkers like CA-125, HE4. My colleagues will get much more into granular detail with these biomarkers. And then you have algorithms that combine biomarkers with the menopausal status to give you a risk assessment. Just to cover CA-125, this is a point you'll hear made over the course of this talk a number of times because it's so important. Yes, it is expressed in the majority of women who have ovarian cancer, about 80%. But as I already stated, the majority of these women have advanced stage disease. It is expressed in only 50% of patients with early stage ovarian cancer. So yes, a normal CA-125 is reassuring, but it is in no way ruling out the possibility that this adnexal mass is malignant. Not only is it not sensitive in the early stages, but it's poorly expressed in non-serous tumors. For example, ovarian mucinous tumors, clear cell undifferentiated sarcomatoid malignancies have a lower chance of elevating the serum CA-125. And though it's approved and it works really well for monitoring primary response to chemotherapy and for recurrence, it is not clear to evaluate ovarian cancer masses prior to surgery, despite the fact that it's used commonly in that situation. The other difficulty with CA-125 is that it is not specific. And you all know that there are a number of gynecologic and non-gynecologic conditions, some cancer, some benign, that can raise your CA-125. Some of the common gynecologic issues like adenomyosis, endometriosis, acute pelvic inflammatory disease, these are entities you see commonly in premenopausal women, which will make evaluation of the CA-125 difficult in this clinical setting. So what does ACOG tell us? Well, the American College of Obstetricians and Gynecology, in their most updated practice bulletin, which is November 2016, gives some guidance on who should be referred for an adnexal mass to a Gyn oncologist. Their recommendations are split between postmenopausal women and premenopausal women, largely because CA-125 does function better in the former group. So if you're postmenopausal, if you have a CA-125 that is elevated, in this case, they're saying greater than 35 units per mil or elevated for your platform, that patient should be referred if she has an adnexal mass. The other reasons to refer would be sonogram findings that are suggestive of malignancy. We mentioned some of them earlier. Those would be nodular excrescences, thick vascular septations, ascites, nodular or fixed pelvic mass on exam, evidence of abdominal or distant metastasis by examination or imaging study, or an elevated score on a formal risk assessment test. For premenopausal women, CA-125 is less useful. Before this most updated practice bulletin, we were told to refer patients to G1 oncologists if the CA-125 is greater than 200. You can see in the most updated practice bulletin, they just say very elevated because the 200 cutoff was just expert opinion. It wasn't based on any studies. But then the other findings would be reasons for referring a premenopausal woman. And again, as mentioned, an elevated score on a formal risk assessment test. So the formal risk assessment scoring test that ACOG is referring to includes some that look at sonographic findings like the risk of malignancy index, but then 3 others that combine serum biomarkers with menopausal status. That would include the risk of malignancy algorithm, the multivariate index assay, and the second generation multivariate index assay. And I'm going to hand you off to my colleague now, who is going to get into more granular detail about these tests and their role in the management of a woman presenting with an adnexal mass.
I am Ashley Gubbels, and I will be discussing adnexal masses and use of biomarkers as triage. This program is sponsored by Abbott, and I'm presenting on behalf of Abbott. Information contained in this scientific presentation is from me and does not represent new or implied product or regulatory claims. Objectives for my discussion will be reviewing the frequency of adnexal masses, both malignant and non-malignant, reviewing serum markers, and discussing the use of biomarkers as triage, whether that is surgery versus watchful waiting, surgery with a general gynecologist versus an oncologist, or route of surgery, minimally invasive or open. And we'll also review a case presentation. The true incidence of adnexal masses is unknown. A normal functioning ovary will produce a follicular cyst about 6 to 7 times per year. And most of these are ultimately self-limited and will resolve within the course of a menstrual cycle. The differential diagnosis of a persistent adnexal mass is broad, but diagnosis is generally presumptive in the absence of a tissue biopsy. The risk of malignancy varies by age group. So in the premenarchal and adolescent age groups, about 80% and 50% of masses are actually malignant, respectively, with most of these being germ cell tumors. In the reproductive age groups, only about 10% are malignant, while this increases to 20 to 30% in the postmenopausal grouping. The incidence of epithelial ovarian cancer is 1 in 70, or about 1.4%, and the median age of diagnosis is 63. The overall 5-year survival rate is around 50%, and this chart shows the breakdown of the incidence and survival by histologic subtype. So a variety of serum markers exist depending on the type of tumor. CA-125 has historically been the primary tumor marker used for sort of classic ovarian cancers. Tumor markers are primarily approved to help triage the likelihood of malignancy, but are actually inadequate for screening purposes. Cancer antigen 125, or CA-125, was discovered in 1981. It's a protein expressed in epithelial tissues, which include mesothelial lining of the pleura and peritoneum, and the Mullerian cells of the fallopian tube, endometrium, and endocervix. Surprisingly, CA-125 is not typically expressed by the surface of the epithelium in benign ovaries. Testing for CA-125 is approved by the Food and Drug Administration for monitoring the response to treatment in women with ovarian cancer, but it is frequently used off-label to help categorize the likelihood of malignancy in an adnexal mass. CA-125 is elevated in approximately 80% of women with epithelial ovarian or tubal cancers. Unfortunately, this means it's normal in about 20% of cases, particularly as high as 50% of early-stage cancers. A meta-analysis showed that CA-125 testing has a sensitivity between 69 and 87% and a specificity between 81 and 93% for diagnosing cancer in postmenopausal women. The performance of the testing improves when it's combined with pelvic ultrasonography or other markers. ACOG recommends that all postmenopausal women with a worrisome adnexal mass and a CA-125 level greater than 35 units per ml be referred to a gynecologic oncologist. In premenopausal women, quote, very elevated CA-125 levels should arouse concern, and this has ultimately been defined as expert opinion, being greater than 200. Human epididymis protein 4 is another biomarker. It is a protease inhibitor that's expressed by malignant epithelial ovarian cells. It was FDA approved in 2008, also for ovarian cancer surveillance only. Subsequent research examining HE4 in combination with CA-125 in the context of menopausal status actually led to the development of a logistic regression model as a diagnostic tool in women with a pelvic mass. The threshold for a positive test is ultimately assessed by the clinician in terms of defining the patient as pre or postmenopausal. HE4 has been shown to have a lower to similar sensitivity, but a superior specificity than CA-125. One benefit of HE4 is that it is not affected by conditions like endometriosis. It is, however, important to be aware that it's increased in smokers or those with a decreased GFR, and can actually also be decreased in OCP users. Combining CA-125 and HE4 as complementary tests improves specificity to 65 to 80% total, and the area under the ROC curve is high in combination. In addition, while HE4 levels vary, as I mentioned, in smokers or those on combined oral contraceptives, simultaneous CA-125 evaluation is not affected by these variables and thus should allow better interpretation of abnormal HE4 levels. So the risk of malignancy algorithm, or ROMA score, is a logistic regression model which combines both CA-125 and HE4. It was first proposed in 2009, and it is meant to be used as a diagnostic tool in women with a pelvic mass and classifies patients into high risk or low risk for ovarian cancer based upon scoring. The score is a predictive index calculated with equations that differ, again, based on the patient's menopausal status. And the values presented depend on whether you are using the test inside the US or outside of the US. There are various calculators. This is an example of the University of Rochester's ROMA calculator, which is available for free. ROMA also has a high sensitivity in differentiating benign versus malignant masses and 100% sensitivity in premenopausal women. It also has excellent negative predictive value in the premenopausal and early stage malignancies. Other combination tests include OVA1 or Overa, which itself includes HE4. These are meant to help determine which women need referral to a gynecologist. The downside to these labs is that they are proprietary and must be run by a specific laboratory, as well as inherently cost more due to the increased number of markers included. Clinical risk assessment should take into account the findings on imaging, typically based on an ORADS assessment, and patient risk factors. So normal tumor markers may often be used to reassure oneself about planned observation, although it is important to keep in mind that this is not their intended use. If surgery is indicated, ROMA can be used to stratify whether the procedure is most appropriate for a general gynecologist or a gynecologic oncologist. Those with a high-risk ROMA score should be referred to Gynecologist. This helps to decrease the risk that the patient may either require a second surgery for staging or undergo potentially unnecessary chemotherapy. A 2009 study showed that 93.8% of cases of epithelial ovarian cancer were classified as high risk before surgical exploration. Thus, the frequency of patients inappropriately undergoing surgery with a gynecologist should be much lower than those evaluated by CA-125 alone. Tumor markers do not solely dictate the route of surgery. So given the known benefits associated with laparoscopy, a minimally invasive approach is appropriate if there is no evidence of advanced stage disease and the abdomen can be entered without rupturing the mass. Washings, of course, should be obtained and appropriate precautions should be taken to avoid any spillage of contents. So the following is a case from 2013 while I was actually a general OBGYN in a small military base that did not have access to subspecialists. The patient that presented was an asymptomatic 29-year-old female who originally presented to her primary care provider after 6 months of trying to achieve pregnancy. A pelvic ultrasound was obtained which showed bilateral complex adnexal masses, and a subsequent MRI showed a complex right ovarian cyst and possible left hydrosalpinx. She was referred to the gynecology team for evaluation. While I don't recall her specific CA-125 level, I know that it was below the recommended value for referral to Gyn-Oncology. The patient underwent a laparoscopic right ovarian cystectomy and possible left salpingectomy was planned for suspected endometriosis. Upon entry, the patient was noted to have a right ovarian cyst and peritoneal stutting more consistent with endosalpingiosis, as well as a papillary growth under the left ovary. Given these findings, a right oophorectomy and a biopsy of the left adnexal mass were obtained. Initial pathology showed at least a borderline papillary serous cystadenocarcinoma. She was subsequently referred to Gyn-Oncology and underwent a second surgery for staging and subsequent chemotherapy. So this case really highlights a situation in which HE4 or ROMA may have and statistically would have increased the likelihood of malignancy or diagnosis of malignancy preoperatively and avoided 2 short interval surgeries. So now I'll pass it over to my colleague to discuss the use of ROMA testing in a rural clinic.
Hi, my name is Dr. Makunda Abdul-Mbacke, and I'm here to talk about the use of ROMA testing in a rural clinic. The disclosure statement, this program is sponsored by Abbott. I am presenting on behalf of Abbott. Information contained in this scientific presentation is from me and does not represent new or implied product or regulatory claims. As far as who I am, so my name is Dr. Makunda Abdul-Mbacke, and I have been practicing in rural Southwest Virginia for the past 17 years, and I've been using ROMA for a while to help me take care of my patients and strategize their best care. And so that's the reason why we're going to talk about how I use it and how I think it can be helpful. So the objective is to understand the importance of using the ROMA test for distinguishing ovarian cysts in a rural clinic setting. Ovarian cysts, as you know, are one of the most common problems seen by OB-GYNs. There are more than 3 million cases per year in the US. For the most part, they remain asymptomatic and will resolve in a few months. Complex cysts that have solid components, papillations or septations do require further workup. And of course, if a person is in pain, which could mean that it's torsion or perhaps severe endometriosis and endometriomas, those might require more workup and possibly surgery. But for the most part, cysts are asymptomatic and resolve on their own. The particular challenges in rural settings is just our lack of resources, our limited resources. My community has lost over 10 OBGYNs in the past 15 to 20 years that have been down here. So there's limited access to diagnostic tools. It's hard sometimes for us to get ultrasound techs. It can be hard for us to have other OBGYNs, and definitely for my patients, the closest gynecologic oncologist is an hour and a half to 2 hours away. So we want to be mindful of the limited resources and use them appropriately. And we also want to be mindful of our patients and their day-to-day lives. As I said, I practice in a rural community. Many of my patients are on Medicaid. Many of them are wage, shift workers and hourly wage workers. So that means that taking time off of work definitely affects their bottom line. And so I try to keep all of that in mind in working them up and trying to give them the best care possible. The beauty about ROMA is that it combines the CA-125 and HE4 to calculate a risk score. It's used to assess the likelihood of ovarian cancer in women with adnexal masses, including cysts. Premenopausal women, if they are less, if the value calculated is less than 1.31, they are considered to be at low risk. And for postmenopausal women, if the value is less than 2.77, they are considered to be at low risk. And any values higher than those in either group will trigger the fact that, now that their risk is increased, what to do next. And I really appreciate the fact that they do break it down into premenopausal and postmenopausal. I think that is super helpful with helping to triage the patients. The further advantages of ROMA that it's non-invasive, it's easily available. I have worked with two large companies, lab companies, and both of them have had easy access to it. It is cost effective, and it can help triage high risk cases, and it helps me with my referral decisions because it lets me know if they're high risk that they're not someone that I would want to operate on locally, and that there's someone that I'm going to want to refer to the Gyn Onc. And it helps Gyn Onc also because they see so many patients and they really want to focus just on patients who have cancer or who may have a high risk of having cancer. And so this helps me tell them, you know what, this is the reason why I'm asking for the referral, is because her rate was, increased, and, she has this complex mass and I'm concerned for cancer. So I think those are the ways that I use it to help me get the best care for my patients. So interpreting the results, as I already alluded to, in my situation, because I'm one of the few OB-GYNs on staff at the hospital and there isn't a Gyn Onc on staff, I would not operate on anyone that I had a serious concern about with cancer. In my training, I trained at University of Pittsburgh. We definitely, generalists often would operate with a Gyn Onc because the case, the patient was ours and we wanted continuity of care. And so, there's a lot of different practice settings, but for me in a rural setting with limited resources and limited colleagues to help out, I would not do a cancer case at our hospital. And so that would be a definite referral to Gyn Onc. Low-risk patients I'm able to keep in my practice. We have shared decision-making about whether we want to continue observation and repeat the ultrasound in 3 to 6 months. And or if they want to move towards surgery just because maybe there's some discomfort or they're not comfortable with waiting. But it's a definite benefit to be able to tell the person that based on the testing, it appears that your situation is a low-risk situation, and it's something that we can watch. Limitations of the Roma test: the sensitivity is 76% and the specificity is 95%. It is not a definitive diagnosis, and so there are sometimes patients or sometimes scenarios where you are still concerned or the patient has pain, or the patient just does not want to take a expectant management approach, wants something done. The Roma test does not give you a definitive diagnosis. It does tell you whether someone is high risk or low risk for having epithelial ovarian cancer. On this slide, we can see that the Roma is superior to just doing the CA-125 by itself. It shows similar sensitivity as CA-125, but higher specificity and positive predictive value, especially in postmenopausal women. If you look at the graph, you can see the area under the curve is highest for the combined Roma test, therefore a decreased false positive rate with using the Roma test versus the CA-125 by itself or the HE4 by itself. So let's look at a couple of cases that I have been involved with. Case study number 1 is a 35-year-old woman with a history of dysmenorrhea and menorrhagia. She'd been stabilized for a number of years using continuous OCs. However, she desired to conceive and stopped her contraception. The painful, heavy periods resumed, and a year after stopping contraception, she experienced severe pain that doubled her over. Evaluation in the emergency revealed that she had bilateral complex adnexal masses approximately 8 to 10 centimeters. The outside facility recommended surgery. Patient was seen by me, and a Roma was used to help triage the patient. The result was that it was low risk. The Roma testing showed that it was low risk, that it was an epithelial ovarian cancer. And with shared decision-making, she decided to resume the oral contraceptives and repeat the ultrasound in 4 months. At that time, her ovaries had decreased back down to normal size. And in this scenario, she's been able to maintain her fertility and avoid surgery. Case study number 2 is a 38-year-old G2P1011 who presented to her OBGYN after miscarriage and was found to have a 4-centimeter simple cyst on her left ovary. It was an incidental finding and the patient had no symptoms. However, her OB-GYN brought her back in several times to do repeated ultrasounds over the course of 3 months. The cyst was stable. It appeared to be simple. There was no increase in size or symptoms. However, her physician recommended removal of the cyst, and Roma testing was not done. At the time of surgery, instead of a cystectomy, an oophorectomy was performed. Patient suffered ovarian failure, premature menopause, and eventually she did seek legal remedy because indeed the cyst that was removed was benign, and she felt that she suffered a lot from useless surgery that was not necessary. And so I think, again, with shared decision-making, this was something that the Roma test would have been most likely low risk, and it would have been a situation where she would have been able to wait perhaps 6 months and then repeat the ultrasound, and perhaps it would have been, it would have shrunk or not been there at all. What happens with me often is it would have been a cyst on the right side this time instead of the left side, just because she is, 35 and still ovulating these cysts do form, as we know, and these follicular cysts, simple cysts, are not something that we really should be chasing down and doing surgery for. So I just want to thank you for your time. I hope that this was helpful, understanding how I use Roma testing for my patients and how it's been a benefit. Thank you.
Thank you so much, Dr. Holcomb, Dr. Gubbels, and Dr. Abdul-Mbacke for your informative presentations. We will now start the live Q&A portion of our webinar. Unfortunately, Dr. Gubbels is actually in the operating room at the moment, operating on a patient with an adnexal mass. So she is unable to join us. But if you have any questions that you would like to ask our speakers, I would encourage you to click on the Ask a Question box located on the far left-hand side of your screen, and we'll answer as many questions as we have time for this afternoon. I will kick it off with a question to Dr. Holcomb and Dr. Mbacke. You know, I've found in my experience working in medical affairs that there seems to be a little bit more uptake of use of the Roma algorithm outside of the US, in Asia and in Europe, than there has been in the US, where I often find that there are obstetrician gynecologists who I speak to who aren't aware that the algorithm exists. I'm wondering if you have any thoughts as to what may be some of the barriers to adoption, not necessarily in an academic medical center, but in a community practice setting.
Yeah, I'm happy to take that question. I haven't the international lens that you have, so I haven't noticed the difference. And if that is really the case, I think one of the barriers that's probably happening in the United States, well, I think it's twofold. One thing, I think a lot of practitioners erroneously think that CA-125 is enough. They don't realize that CA-125 has been, a blessing to GYN oncologists, but it's really only proven to be able to do one thing really well, and that's monitoring somebody through the course of treatment for ovarian cancer. So many will rely on CA-125 alone. So it's not that people aren't using blood tests. I think they're just using not a good blood test for doing risk stratification in a woman with an adnexal mass. And then I think also in some European countries, I think there's just much more standardization of care that comes from a more socialized medicine, arrangement. And I think of like the National Health Service in the United Kingdom, for example, where I think a lot of practitioners are following and may be forced to follow some algorithms just to move the patient along. And those are evidence-based algorithms that'll keep them more closely hewed to the evidence than what you might see in the US.
Terrific.
I would agree, for my close colleagues that are friends, I know that we all use it, but I do know that when we were in training, we were definitely taught more about CA-125, CEA. When we were in training, there wasn't a Roma, it had not been developed yet. So we used the CA-125, and it may just be one of those things about education, like what we're doing now, just getting the word out so that people are aware that there's, new and improved testing that can help them do risk stratification with their patients.
Yeah, I think especially for those early ovarian cancers, it's important that people recognize why CA-125 may not be enough in and of itself, right? We're all familiar with the cases that are pretty obvious by the time you get imaging that there's disseminated disease going on. But I think our goal is to catch some of these cases earlier and have that surgery done before it's a stage 3 malignancy. Dr. Abdul-Mbacke, I'm particularly curious in your practice because you're really sort of the boots on the ground, having that conversation with a patient who is making that decision, as you said, whether or not they're going to take off work and go to another consultation with another provider, or if they're maybe going to wait a little bit longer for a procedure. How does the algorithm and the results help you in terms of that shared decision-making process, both in terms of motivating the patient and then potentially maybe getting that patient in with a specialist who's a bit overwhelmed?
Yes, so it's definitely helpful for me to get in getting the patients in the area that I'm in Virginia. Our chief area would be Roanoke, and that's about an hour and a half to 2 hours away. And then UVA is 3 or more hours away for a gynecologist. And so recognizing, the time and effort of the subspecialist, I want to make sure that I'm sending them patients that really need their help. And so the Roma helps me prove that point. Certainly, if I did an ultrasound and there were papillations and ascites, while I still might do the Roma, my clinical judgment is going to tell me this patient needs to be seen by a Gyn Onc. And I think they would agree also, but it's more for the patients also of, using it so that we can try and figure out who may need to do their surgery, whether it's someone like me, benign gyn, or whether it's Gyn Onc. And so the patients also appreciate the testing as far as understanding that, we're looking at tumor markers. This can give us some more information. It's not all or none scenario, but it does help us stratify you as in regards to whether you're high risk or low risk. And so it helps the patient understand the necessity for the referral and, if it's needed. And then it also helps me with getting them through the door, knowing that I did everything that I could do before I sent them on to the subspecialty.
Dr. Holcomb, I wonder if you have, I'm sure you do have experience, but if you could speak to a little bit sort of the scenario that where you have a conversation with a patient who hasn't necessarily had the right surgery or their surgery with the right provider the first go round, and what that looks like in terms of potentially additional complications or risks to them, or changes in how you can counsel them about outcome.
Sure, and that's not an uncommon, scenario. Usually, what happens is the person is sent. They had a surgery for an adnexal mass that was presumed to be benign, and usually, what I hear is that the referring physician will say, "But I looked in the upper abdomen and everything looks fine. This seems to be an early stage cancer." And, ovarian cancer is very misleading in that although the majority of people present with advanced stage disease, for those who present with apparent early stage disease, they can have microscopic spread that impacts the outcome and really determines whether or not they should be getting adjuvant therapy in the form of chemotherapy, which can be life-saving. And so the reassurance that says, I looked up in the upper abdomen can only be taken so far. To be honest, very often the person has, an op note that doesn't describe a really extensive look around, or they've had a surgery through a very low, very cosmetic incision, but one that wouldn't give you access to see the upper abdomen. And the studies show when we go back and do comprehensive staging, if that person didn't have an omentectomy and didn't have lymph nodes biopsy, a significant number of them will be upstaged. And even if it's microscopic, it has a significant impact on that woman's risk of recurrence. And so there's two sides of it. There's one, if she's fortunate to get into the hands of a Gyn oncologist who takes her back and does the appropriate surgery, she's now bought an extra surgery that could have been done theoretically the first time. I realize that's not always possible in every situation, but so that's a downside. And then two, if the second surgeon doesn't go back and do that required surgery, they may be sticking their head in the sand and saying, I think everything's likely okay, let me not give this woman an extra surgery and chemotherapy. And I've unfortunately seen cases where that was the wrong decision.
Yeah. which, obviously we all want the best outcomes for our patients. And I think every general gynecologist who's seeing a patient with an adnexal mass is trying to make the best decision for their patient. And this is just another tool in their armamentarium. A question we have that's recently popped up, and we know that Roma isn't used for screening of asymptomatic patients, but this listener or attendee is asking if a premenopausal patient, perhaps somebody who's 37, had a mother die of ovarian cancer, are there recommended steps she and her sisters should be taking to make sure she catches a potential ovarian cancer herself?
That is a great question. And the way I think of it is, are there steps that woman should be taking to make sure she never develops an ovarian cancer? Because we actually don't have an effective screen for ovarian cancer. We've got CA-125, we've got transvaginal sonograms, and we've got decades of research in the United States and elsewhere showing that screening for ovarian cancer doesn't appear to change the risk of dying of the disease. So I think most of us understand that ovarian cancer has a genetic component to it. If you have a strong family history, you've got a mother or sister who has this relatively rare disease, it may be that your family's carrying a genetic predisposition to ovarian cancer. And that patient should be referred for genetic testing. Or if you have the ability to do genetic testing in your office yourself, the woman should be tested. If the mother is alive and you can test the woman with the index cancer, that's the best thing. If that person has passed and they're not available for testing, the next best thing is to test the sisters, in this case, a 37-year-old. At what age do you start testing is going to be determined by the age of the youngest affected family member. If you have somebody who had ovarian cancer at 45, you really want to start testing the family at around 35, because there tends to be earlier presentations of these cancers. And so if you are identified as having a BRCA mutation or a Lynch syndrome or some other genetic predisposition, there's a powerful tool in preventive surgery, risk-reducing surgery, that requires prophylactic removal of the tubes and ovaries, or in case of Lynch syndrome, maybe the uterus as well. But that's the best you can do for that patient, is make her aware that she's in harm's way, and then explain to her the unfortunate situation in ovarian cancer, where we only have risk-reducing surgery right now as a proven tool.
I would just join in to say what I talk to my patients about often, perhaps not exactly in that scenario, but it may be a patient who will say something like, well, cancer runs in my family, and they won't be very specific about what types of cancer, but the discussion that I have with them is that the two leading causes of preventable death in America are related to obesity and smoking. And so assessing those risk factors are a big part of the practice to try to mitigate, and prolong their lives, is trying to address their weight issues, and then also whether or not they're smokers or not.
I have another question that's a really practical one for you, and Dr. Mbacke, you probably have this experience very much in terms of what lead time do you need between before surgery to get results back from somebody who you're interested in screening, and so our listeners understand anything that has to go into that algorithm, other symptoms that need to be considered before you're sort of plugging numbers into a Roma calculator?
Usually, the test is to help you when you already have identified a cyst. So I've got the ultrasound, and so if they have a cyst and I have some history about what their symptoms are, and, putting all of that together, the history, the physical, the imaging, and then we'll order the Roma testing. The Roma testing, usually we get it back in less than a week. And so putting all of that together, that's when I can make a decision about whether or not they're going to be referred out of the practice, or whether we're, through shared decision-making, they feel comfortable, staying in the practice and proceeding with surgery or proceeding with observation.
But essentially, it's your normal lab turnaround time.
Pretty much, yeah. It's not the genetic testing takes, like if I was going to do BRCA or something like that, that takes up to 2 weeks to get the results back. And I guess the other thing that I should point out, since I do see a lot of patients with government assistance, I have not had any blowback from sending the test. So I haven't had a patient that came in and said they got an incredible bill from testing, nor I've had no, issues with payment. So if someone, versus the reason why I jogged my memory, versus getting the genetic testing, I get blowback from that from the private insurers and from Medicaid, even when they filled out the whole genealogy of who has cancer in their family. It's not the easiest thing in the world for me to get that approved, but it's been surprisingly easy for me to get the Roma testing. I don't even do any prior auth or anything. I just put the code down that they have a left ovarian cyst or whatever, and it's been going through.
Yeah, one of the things I wanted to add to that, one of the amazing things I think about Roma is that it doesn't take into account sonographic findings. For example, there's other risk stratification tests like risk of malignancy index, which looks at sonographic features and CA-125 and menopausal status and gives points. Whereas this test is just looking at menopausal status, HE4, and CA-125. But that's because the indication for this test is really in a woman over 18 years of age who you've already decided needs surgery. So you've already weighed in a clinical suspicion that says, for whatever reason, I think this woman needs surgery, and this test is being used to determine who should be best doing that surgery. So, when you said, are there any other things that you have to worry about as symptoms that need to be considered before using Roma? I would say if you have somebody that you believe has a high risk of malignancy, they've got all the symptoms of ovarian cancer, and maybe you feel a fluid wave on exam or there's free fluid on the sonogram, go ahead and send that patient to an oncologist. I think that person has enough going, and ACOG would agree with this, that you don't need a formal risk assessment tool in somebody who's got very worrisome symptoms or high risk from family history. I think Roma is going to help you with the vast majority of the patients, because the vast majority don't have an obvious metastatic cancer, and they are premenopausal women, and they don't present with a lot of family history. That's where we do, I'm sure, most general GYNs see the majority of their adnexal masses fall into that group, where I think Roma is really helpful. But I would say, again, to remember, I think people do use the test sometimes to decide whether in joint decision making, as you mentioned, that they may decide not to operate, but that's not really the indication for this test. It's for somebody who the surgery's already been determined they're having, and it's really just determining who's doing it. So I would say keep your clinician's hat on. Don't put all the weight on Roma.
Terrific advice. Terrific advice. And with that, it looks like we're actually almost out of time. So I certainly want to thank both you, Dr. Holcomb, and Dr. Abdul-Mbacke, and Dr. Gubbels, who is often the OR, for your time today, and for all you do for your patients, both Ovarian Cancer Awareness Month and every month of the year. We'd like to also thank LabRoots and our sponsor, Core Diagnostics at Abbott, for underwriting today's educational webinar. Before we go, I'd also like to thank the audience for joining us today and for their interesting questions. Any questions that we did not have time to answer, or those that were submitted, we can also make sure that they can be addressed by the speakers via the contact information that you provided at the time of registration. The webcast will be available to be viewed on demand, and LabRoots will notify you via email as soon as the recording is available. I thank you all very much for joining us and hope you have a wonderful rest of your day.